Hi, I'm Dr. Virginia Kane, Associate Professor of Medicine in the Division of Infectious Diseases at Indiana University School of Medicine in Indianapolis, Indiana. I am also the chair of the infectious disease section for the National Medical Association, which is the oldest and Black physician net group in the country. And on behalf of the National Medical Association and blackdoctor.org, we are delighted to present a webinar today talking about the critical aspects of the new tools we have available to prevent HIV infection in our vulnerable populations in our communities that appear to be at high risk for this HIV infection. And so I just want to start by acknowledging the internal medicine section, which is hosting this event from the National Medical Association. And I'm going to ask everyone to access a link in the chat in order for us to complete a pre-test. And if we can, I'd like to have our pre-tests put before our viewers. So the pre-test questions that you will be looking at with our latest clinical update on long-acting antiretrovirals for HIV pre-exposure prophylaxis is number one. What is the frequency of injectable cabotegravir PrEP? Is it 2 months? Is it 6 months? How to screen for HIV while on PrEP? Do you need an antibody test or an HIV viral load? And which of the following medications are approved for HIV pre-exposure prophylaxis? And so you will see the different medications bictegravir, tenofovir, iptrazidapine. You have the third choice, the fourth choice, cabotegravir, or all of the above, or just maybe B, C, and D. And so I believe we have, if I could, to see the next set of slides. Okay. So we'll get started, though, and give you time to reflect on those pre-test questions. And the next person I want to introduce you to is Dr. Sashi Nair, who is an infectious disease fellow at the University of Minnesota in the Department of Internal Medicine and International Medicine. He has clinical interests in the immunocompromised HIV patient population. He's interested in medical education as well as outcome research. A graduate of the Medical University of Ahmedabad University in India, with his internal medicine residency at Henry Ford, and currently an infectious disease fellow at the University of Minnesota Medical School. If we can have our first speaker, Dr. Nair.
Thank you so much for that introduction. It's a real pleasure to be speaking here today. I'm just going to get my slides set up.
And while Dr. Nair is getting his slides set up, I just want to remind people that you have the participants, you have the ability to link up in the chat. So if you have any questions, we'll be happy to answer them after each presentation. Thank you. Dr. Nair.
Excellent. I hope you can see my slides okay. Wonderful. So I'm talking today about long-acting injectables for HIV prevention. And HIV prevention is something that's so important to me, and that's really only become more important as I've gotten more experience in medicine. And every time I get a new HIV patient, I'm sort of happy on the one hand that they don't have to go through sort of the horrible things that happened in the past with new HIV. We have wonderful treatment options available, but it also does really break my heart on the other hand, just thinking that this is really a preventable illness, and we do have tools, maybe not tools that are available to everyone or work for everyone, and adding more sort of arrows to our quiver to prevent HIV is something that's really important to me, something I want to talk about today. I have no disclosures. We already saw some of the pre-questions, just talking about the frequency of injectable cabotegravir PrEP and how to screen for HIV while on PrEP. So my learning objectives for everyone today, and I think the key takeaway points would be just to learn what's the current landscape of PrEP, learn about what injectable HIV medications we have, look at the evidence for injectable PrEP, learn about something called the tail phenomenon, which is very important, and then coming into the clinical aspects of how you can actually help your patients get this out into the real world. So how to prescribe injection PrEP, what to monitor while on therapy, how to address patient questions and difficult situations, and then look at the different resources available to you, and also look at what's coming down the pipeline and on the horizon. So as an infectious disease person, I could not start a talk without just doing the HIV life cycle here and reviewing the different drugs we're going to talk about. You can see the HIV virion, it attaches and fuses to the host cell. The HIV RNA is reverse transcripted to DNA, which integrates with the host genome. That then gets transcribed into different proteins, and that gets assembled into new HIV viruses. And we do have multiple different medications to target all of these different points. But from a prevention perspective, there's really 2 drugs, maybe 3, that I want to talk about today. So the first is a combination of tenofovir and emtricitabine. And those are 2 different drugs that act at stopping the reverse transcriptase enzyme. And then the second drug and main drug I want to talk about is cabotegravir, which stops integration with the host genome. And I'll also put a little plug for lenacapavir, which is a capsid inhibitor. So I'll be using a few terms through today's talk to talk about tenofovir and emtricitabine. So tenofovir actually comes in 2 different flavors, so to speak, and one is tenofovir disproxyl fumarate, TDF, and the other is tenofovir alafenamide, TAF, and emtricitabine is abbreviated as FTC. So you'll see the terms TDF-FTC and TAF-FTC a few times in my talk, but mainly I'll be talking about cabotegravir. If you're wondering what the difference is, TDF has been around a little bit longer. TAF has slightly better renal and bone outcomes in the long run for patients, but it's a newer medication and is not studied in all populations. But my main point is about cabotegravir. So what we have going on now in terms of oral prevention, which isn't really the focus of my talk, but for just as a refresher to get everyone up to speed. So there's either daily TDF FTC or TAF FTC. And the TAF form, which I mentioned, is newer. It's not approved for those assigned female at birth. And these medications require about 7 days to reach therapeutic levels rectally and 21 days for vaginal protection. They're taken daily. They're very effective. There's also a 2-1-1 regimen, which some people in the audience may have heard about. It's not currently CDC recommended or FDA approved. It's with the TDF FTC, and it's 2 pills, 2 to 24 hours before sex, and then daily for 48 hours after sex. It's only studied in penetrative intercourse or receptive anal intercourse, and it's not studied in vaginal intercourse. And this may be slightly less effective, slightly more complex, but for some patients, it's better than nothing. And if there's a patient that this is all they'll take, I will offer it to them with the caveat it may be less effective than a daily prescription. So when we look at how effective these medications are, or oral PrEP is, it really depends on how much your patients are taking. There's some studies where the efficacy is 80 to 90%. When the adherence is 100%, you can see on the right side of the slide in the PROUD study. And you can see that the efficacy drops quite significantly as adherence goes down. So if your patient asks you how effective are these medicines, it's really up to your patients and up to them how much they're able to or willing, or how much sort of life allows them to take their medications every day and get access to the medicine. And that's the real drawback with any oral medication, including oral PrEP. So when we sort of look at that previous slide, you might think that adherence is a problem. And I put that in quotes because I find the term problem sort of patient blaming. I think it doesn't really take into account real world circumstances that all of our patients face. It's looking at a difference between what's seen in a trial and then what's seen in the clinic and in patients that have significant barriers to access to medication. They may have mental health conditions or other social conditions that stop them from taking a daily medicine, or even a financial burden that doesn't allow them to regularly take their medications. And when I see that a medication is dependent on a patient taking it every day to be effective, I think of this personally more as a drug problem rather than a patient problem. And I think we as a medical community can do better. In infectious disease, we've been looking at this for a while, trying to avoid patients having to take medications every day. Everyone must be familiar with benzathine penicillin for syphilis. Your one shot, or come back in a week for your second shot, and you are done. There's no long course of daily medications. Even in LTBI, we've been working towards this with weekly rifapentine and isoniazid that doesn't rely on patients remembering to take their medications every day for latent TB. There's now single-dose dalbavancin, which lasts for 10 to 14 days for MRSA skin and soft tissue infections. The patient comes into the ER, they don't need a PICC line, they don't need a prescription for linezolid or Bactrim. They can just get a single infusion and be done. And another pioneering work we've actually been working on at the University of Minnesota is a single dose of liposomal Ampho-B for cryptomeningitis, which has the potential to revolutionize the treatment of that disease in Africa, where a daily IV infusion for 2 weeks is just not an option for many patients. And I think HIV prevention is sort of in the same vein. So here we have injectable HIV medications. So cabotegravir is really the one FDA-approved anti-HIV medication, which is currently on the market. There is lenacapavir as well. And cabotegravir is really a wonderful drug. It's in the class of the integrase strand transfer inhibitors, and these have a very high barrier to resistance. Very favorable side effect profile. Gone are the days of the protease inhibitor lipodystrophy or other issues, and it's given every 8 weeks as maintenance. One of the other, plus points of cabotegravir is it doesn't need to be renally dosed. It doesn't matter if your patient has advanced CKD, is on dialysis, or maybe even hasn't had their creatinine checked in a while. It doesn't matter. It's not renally eliminated and doesn't require monitoring. The one side note, a technical point, is it doesn't suppress hepatitis B. Some of the other HIV PrEP options, tenofovir, the different tenofovir emtricitabine combinations, do suppress hepatitis B. So for some patients who are on those with a hepatitis B aspect in mind, switching to cabotegravir might not be the right choice. And then lenacapavir is the other capsid inhibitor that's very close, hopefully, to being moving towards the FDA approval process. There was very good efficacy in a lot of studies. There's currently a trial for PrEP, which was paused, not really due to issues with the drug, but more issues with the borosilicate vials and some supply chain issues. And this is actually anticipated to be a twice yearly injection. So every 6 months, get your injection and done. And this is where I think we've made a revolution in HIV medications, both of which will be able to be used for PrEP, including cabotegravir, which is already FDA approved. So when we look at the evidence for these medications, a lot of times what we do in the clinic is often shaped by someone who designed the trial, and we're a little bit stuck in our lane of doing things the way they were done in the trial. I think fortunately for cabotegravir, the trials were, some of the best run, most diverse trials that I've seen recently in HIV. They were randomized, double-blind, double-dummy, placebo-controlled, multi-center trial, over 2,000 in either arm. It was cabotegravir versus oral PrEP. And there was 13 new HIV cases in the cabotegravir out of 2,000 and 39 in the oral PrEP out of 2,000 as well. You know, we talk a lot about equity in medicine, and one of the real areas where equity is lacking, unfortunately, as we all know, is trials. Fortunately, the cabotegravir trial was not the case. You know, 50% of the patients were African American, and that's really important because these are groups that are significantly and disproportionately affected by HIV. The Hptn 083 trial, which is the landmark trial, was all male-bodied individuals, so either 87% males or 12% transgender women who have sex with men. There is a separate trial in those assigned female at birth. And when we're comparing the injection to the oral, in this trial, there was 74% adherence to the oral medications. So that likely represents a real-world adherence that these patients were able to do. So the protocol of the trial, which is important because that's how we prescribe it in clinic. So there was an oral lead-in with the medication for 1 month just to make sure there was no safety issues. There were no safety issues, so this oral lead-in is now optional. And then they gave a cabotegravir injection at month 1, month 2, and then every 2 months thereafter. And these patients were followed for a long time, 153 weeks. And once the trial ended, they were given oral PrEP to take after completion of the trial. And they had periodic HIV and STI testing. If you're wondering about those assigned female at birth, so there's the Hptn 084, similar protocol, similar efficacy. There was 3 in the cabotegravir arm, so 3 out of 1,600 and 36 out of 1,600 in the oral arm. And it was actually stopped early due to superiority of cabotegravir. So if you're wondering, there were a few people who got cabotegravir and still got HIV, and who were these people? How do I stop my patient from becoming one of those patients? So if you look at the patients who were breakthrough HIVs in the Hptn 083, and just as a reminder, that's those born as males, out of the 13 breakthroughs, 4 were actually positive at enrollment, so they were in the window period of HIV, so not really a breakthrough. 5 out of 13 occurred in those who did not follow for regular cabotegravir injections. So either they got 1 or 2 doses, and then several months later, all of them were over 2 months after their last dose, then wound up getting HIV. So again, not really a breakthrough, but a real-world adherence issue that our patients may wind up facing. 3 out of 13 were actually those who were intended to get cabotegravir, but actually never got it due to dropping out of the trial or switching arms for various reasons. But 4 out of 13 patients, or 4 out of 2,284 in the cabotegravir arm, actually did wind up getting HIV. And this is a very small but non-zero percentage that should be remembered. And this is probably due to baseline integrase resistance in the population. And in the female arm of the study, or the female version of the study, there wasn't actually any who were regularly getting cabotegravir who wound up developing HIV. So one thing to know with cabotegravir is the tail phenomenon, and this is an important thing for us as physicians to understand to then counsel our patients. So cabotegravir is great. It lasts at an effective level in your body for 2 months, maybe 3. But after that 2-month time period, there's a time frame where the drug levels are not 0. They're not enough to protect you. And that's what you can see here on this graph as the zone of resistance risk. So they have suboptimal therapeutic levels, and patients in this window are unfortunately both at risk for acquiring HIV as well as developing new resistance for HIV during this window. And the duration of this tail phenomenon is about 12 months. So if a patient were to discontinue therapy for whatever reason, this is something to understand, and we'll talk about what to do in this time frame a little bit later. So who's eligible? How do I get this to my patients? Which patients can get it? So adults and adolescents, there's not really an age cutoff, more a weight cutoff, 35 kilograms, who are at risk for HIV. The patients must be HIV negative, which we'll talk about more. There's no GFR cutoff, as there are with the other ones that you can see. There is no data for pregnant or breastfeeding patients. Dolutegravir, another integrase strand transfer inhibitor, is actually associated with very low levels of neural tube defects in some studies. There's no data for this in pregnant or breastfeeding patients, and it's something to consider. Obviously acquiring HIV during pregnancy is a known significant risk to the fetus and the baby. But again, there's no efficacy data. The TDF FTC, so tenofovir diproxyl fumarate M-tricidabine combination, is actually approved for pregnancy and breastfeeding. And in the trials, patients who were found to be pregnant were switched to this. There are a few drug interactions. So basically the enzyme inhibitors, the classical ones that many of us might remember from pharmacology. So that's carbamazepine, oxcarbazepine, phenobarbital, phenytoin, rifampin derivatives. And there's no interaction with hormones or no evidence for interaction with hormones, which is a common patient question. So how do I start this? How do I get this to my patients? So you have to confirm they're HIV negative. Ideally, their HIV test should be less than 1 week before they're getting their infection. They need both an HIV antigen antibody and a viral load to rule out the window period. So this is a key piece of information. One of the safety concerns, really the only safety concern in the study, was delayed diagnosis of HIV. And because this is such a long-acting medication, it may sort of suppress the immune recognition and the antibody tests. So really the best way to detect HIV in patients on PrEP is with the HIV viral load test. So you need to do that before starting. Assess any drug interactions, screen for other STIs. Patients who are at risk for one are at risk for all. So that's checking for syphilis, gonorrhea, chlamydia. And with gonorrhea and chlamydia, just mentioning that it is important to check not only the urine, but other areas where patients may be exposed, whether that's the throat or an anal swab. That's something that should be done. And you should discuss the risk of adherence, the need for adherence, so every 2-month injections. And if they were to discontinue, discuss this 1 year tail period. So there's an optional oral lead-in where you can take the medication orally for a month, or you can start directly with the first injection. There was really no safety events during this oral lead-in, so that's not mandatory or really recommended at this point. You do kind of manage injection reactions, which we'll talk about more with Tylenol, ice packs, warning your patients. And it's a 600 milligram gluteal intramuscular injection. It does need to be given gluteal. And it's a 2-inch needle if the BMI is greater than 50, and a 1.5-inch needle if the BMI is less than 30, sorry. They come back in 1 month for their second dose, and then they get it every 2 months as long as they're at risk for HIV after that. So while you're on therapy, with every injection, you should be checking an HIV viral load. You should address any patient questions, reinforce the need for follow-up. You don't really need labs from a PrEP perspective. The oral medications, you are recommended to check labs every 3 months or so. There was a slight increase in mild transaminitis in the cabotegravir arm of these studies. So maybe you could check an LFT, but it's really not in the guidelines, any need for blood work. And you should check STIs as needed, every 4 to 6 months. The CDC has this wonderful table here reminding us what to check in our different patients. It says in the MSM and transgender women population, you should be checking STIs every 4 months, and in heterosexual patients every 6 months. In my practice, I check patients as often as they think they need to be checked. If it's, every 2 months and the patient says, I had an exposure, then that's something that I would do. I wouldn't really look at their sexual orientation and decide when to screen them. And I might offer every 4 months to everyone, or maybe your patients well and you want to spread it out. But these are really the CDC guidelines on what to do. So the common questions I get in clinic about PrEP are, hey doc, I started this medication, when am I protected? With cabotegravir, it's not really known. There is great data for the oral ones, 7 to 21 days, depending on which sort of orifice is going to be exposed. With cabotegravir, it's unknown. It's probably 1 to 4 weeks. although in the trials, there were no breakthroughs in the early time frame. So as far as we know, it could be immediate. I might counsel my patients to sort of be extra careful for the first month or so. The other question that we get not infrequently, and unfortunately there's misinformation about this in the community, is there interaction with hormones, either birth control or gender affirming? There is no real evidence to suggest any clinically significant interaction. And then, of course, the common question that we all get asked by our patients, I'm starting on this med, doc, what are the side effects? So 3% of patients actually discontinued the cabotegravir due to severe injection site reaction. None of this was life-threatening, but there was pain, swelling, nodules, and some patients couldn't tolerate it and thought that they would do better on an oral pill, which is not unreasonable. 82% of patients do have some injection site pain, but 97% of this was mild to moderate. Actually, 41% was just mild pain. And the average duration is about 4 days for discomfort after the injection. It's less clear. There's not any clear guidance on this, but there was some mild increase in mild transaminitis, maybe some weight gain, maybe some increased depression. But this is something that's ongoing in trials to look at more, not something that was identified in the thousands of patients initially. So with any medications, there's challenges. So your patient says, for me in Minnesota, we get patients, I'm going down to New Orleans for the winter, to Florida for the winter, and I'm not going to make my next injection. What do you do? So if they're going to miss by more than 7 days, you want to bridge them with oral meds for up to 2 months. And more than that, you could continue them on the oral cabotegravir and then maybe reload them. But if it's just 2 months that they're missing and they've been on oral cabotegravir in that 2-month time frame, you can just give them their next dose as if they never missed one. If they want to discontinue PrEP, you can discuss the risk in the tail period, continue screening, and definitely offer the oral, or if you have to, the 2-on-1 PrEP. If you have a positive or ambiguous HIV test, you can involve your local ID provider. There's also a wonderful hotline run by the University of California at San Francisco, which sort of can help with complex, challenging cases. Even as an ID person, our group gets in touch with them from time to time. The real challenge, though, unfortunately, with cabotegravir is the cost. So the sticker price, often patients pay much less or zero, depending on their insurance, but it is $22,000 a year versus $400 for the generic TDF FTC. Currently, because it's such a new medication, it's working its way through the state assistance programs. There is a manufacturer assistance program. And hopefully, because it's so much more efficacious and has the potential for patients who can't be adherent, which you'll be hearing more about in other talks today. The USPSTF had recommendations for oral PrEP for all at-risk adults. And once those recommendations came through, then those are now covered with no cost sharing to patients through all commercial insurance. So if such a recommendation were to come for cabotegravir, potentially then it may be something with a much lower cost. And of course, one day we'll get a generic. But this is a consideration if your patient is uninsured or suboptimally insured, as are unfortunately many of our patients. So just looking at the new horizons, so lenacapavir is shown to be efficacious in phase 1-2 studies. It's every 6-month injection. As I mentioned, the trials are paused right now due to issues with the vials and supply chain, but hopefully we'll go through and this should come relatively soon. There are vaginal rings, which are sort of effective, dapavirine, maybe less effective, and these are unfortunately stalled at the FDA approval process. Really, the big thing, which I'm excited about, is implants. So Ilatravir, it's an NRTI, a nucleoside reverse transcriptase inhibitor. Phase 1 and 2 studies actually show a 52-week drug levels being protective, so potentially a once-a-year implant. And it's actually given with the same implant that's given for birth control. Maybe one day we'll see a co-formulation on the market and patients can get both birth control and HIV PrEP, and that would be wonderful. And then antibody therapy, just like we see for COVID, can be used for prevention. These are things which are making their way down the pipeline. I think lenacapavir is something we should see relatively soon, and the implants would be maybe the not too distant horizon. So I hope everyone maybe has a better idea about the frequency of injectable cabotegravir PrEP and how to screen for HIV while on PrEP. Just gonna go through some of the learning points again. I Loved learning about PrEP and preventing HIV, early on in my fellowship, and it's something that's important to me, and I hope you all learned something. So injectable PrEP is very effective. It's more effective in real-world conditions than oral PrEP. You do need to check both HIV antigen antibody as well as viral load while on therapy. There's an optional oral lead-in, and then you give two 600 milligram doses 1 month apart, and then every 2 months thereafter. Return visits are opportunities to screen for HIV with the viral load and STIs every 4 months to 6 months, depending on the risk you judge for your patients. You can bridge with oral therapy if your patients are gonna miss a dose. And then remembering the tail period is something that should be covered. So if they're going to stop injection cabotegravir, they can go either on oral TDF, FTC, or TAF, or if they think they're not at risk anymore, you just counsel them that this is something to consider. And there are many resources available to assist you bringing this to your patients. I have a few resources here. The CDC PrEP guidelines are wonderful, easy to read, great diagrams. And I think, something that can really bring this out of the ID clinic and into the primary care clinic where our patients are. In ID, we don't unfortunately have enough appointments to see everybody. And if we can get more people in the community prescribing injection and oral PrEP, that would make a huge impact on our patients, our communities, and the long-term outcomes of the patients we care for. And there's a few other resources regarding PrEP here, and I hope everyone learned something, and I hope even one person is curious to bring this to their clinic. That would be a win for me.
Well, we want to thank Dr. Nair for his presentation, and you can see the wonderful resources that he has identified. And I just want to remind any new persons that have come on the broadcast that this is a webinar teaching us about pre-exposure prophylaxis medications for people who are infected with HIV. As you know, these wonderful oral medications and our long-acting injectables are effective at about 99% in preventing HIV infection. So these wonderful tools has the ability to eradicate or eliminate HIV in this country within the next 10 years. And so this is very exciting because when we look at HIV, as you'll hear from our next speaker, we are disproportionately being impacted in our African American communities, and we find that our Black patients who are gay or having sex with other men are at extremely high risk for acquiring HIV infections. And some studies have suggested that in our lifetime, 1 in 2 African American Black males who are gay will be infected with HIV without an intervention such as this, or taking antiretroviral therapy to treat their HIV. So thank you, Dr. Nair, for your illuminating presentation, and we're hoping to see some of the newer regimens that may come out where you may only have to get 1 injection twice a year. Just how remarkable is that? Or a vaginal implant that may be just as effective in a year. So a lot of exciting new preventative tools that are out there for us. And so please, there is a link that you can be added for a chat. And so please look for that link if you have any questions. So our next speaker we have coming on is Dr. Michael Davis. And Dr. Davis is an infectious disease fellow at the University of Minnesota who has clinical interests in HIV care, underserved populations, and antimicrobial stewardship. He completed his medical education at Des Moines University in Iowa, where he obtained not only a medical degree as well as his master's in public health. And after completing medical school, he went on to complete his internal medicine residency through Michigan State University in Grand Rapids, Michigan. And so if we can, we will have Dr. Davis. And I believe currently right now he will be loading his slides.
All right, hello everyone, and thank you for the introduction, and thank you for having me here today. And so today I'm going to be talking a little bit about the epidemiology of HIV PrEP. And to start things off, I don't have any disclosures. And some of the objectives today that I'd like to cover are talking about HIV in the US, HIV transmission, HIV prevention, PrEP, the PrEP gap, and some of the adherence issues. And then I'll briefly touch on the injectables again, but Dr. Nair did a really good job of discussing that in this presentation. And to start things off with a question, which of the following medications are approved for HIV pre-exposure prophylaxis? And these questions we'll hopefully be able to answer by the end of the talk as well. And so the answer choices are A, PO, bictegravir, tenofovir, and emtricitabine, B, tenofovir, alafenamide, emtricitabine, C, tenofovir, disoproxil fumarate, and emtricitabine, D, IM cabotegravir, E, all the above, or F, which is B, C, and D. And then the next question that we'll hopefully be able to answer by the end of this presentation is, which persons would be eligible for PrEP? So is it A, a man who has sex with men with 2 partners in the last 2 months without consistent condom use? B, women who have sex with men with 1 partner in the last month and 1 episode of rectal gonorrhea? A man who engages in IV drug use 1 to 2 times per month with shared needles? D, all the above, or E, A, and C. And so getting into the presentation, so HIV in the US. So in 2019, the CDC estimated that there's about 1.1 million persons above the age of 13 with HIV. About 1 million of those are actually diagnosed, but they also estimate that about 158,000 people are undiagnosed. And this is actually a really important thing, is that there's so many people that are undiagnosed with HIV. And the most common transmission mechanisms that we see is 58% acquire it through men who have sex with men, sexual contact, 26% through heterosexual contact, 11% through IV drug use, and 5% through a combination of men who have sex with men and IV drug use. I think I really want to highlight this undiagnosed statistic, that about 13% of HIV patients are unaware of their diagnosis. And about 80% of those new HIV transmissions are from these people that are unaware of their diagnosis. And this is very key, and I think it highlights the importance of not only screening people for HIV, but also using preventative measures such as PrEP to try to prevent the transmission of HIV from this population that don't even know that they have it. And getting into some of the demographics of HIV in the US, about 77.8% are male, 22.2% are female. And as far as race and ethnicity go, about 40% are Black African American, 28.5% white, 24.7% Hispanic Latino. And these statistics are kind of overwhelming too, because the Black African American population is about 13% in the US, yet they have about 40% of the HIV diagnoses. So there's some very evident disparity in who has HIV. And some other things that the CDC notes are that there's increased rate of diagnosis associated with poverty, unemployment, lack of health insurance, areas with lower household income, and lower educational attainment. And so understanding a little bit more about who's at risk for HIV and this transmission. So transmission of HIV is usually due to exposure to infected bodily fluids. And these infected bodily fluids that I'm talking about are semen, vaginal secretions, blood. And usually the routes of transmission where you're going to be exposed to these infected fluids are through cervical, vaginal, penile, and rectal, usually through sexual contact, percutaneous, referring to needle sticks, and then intravenous, which would be referring to IV drug use. And so getting into, you've been exposed to this bodily fluid through one of those mechanisms of transmission, what happens next? So you get exposed to this infected bodily fluid, and that infected fluid has the HIV, and it infects the mucosa and the submucosa and the lymphatic tissue. And in these tissues, dendritic cells will take up the HIV virus, and usually it's one fit virus that kind of outcompetes the rest. And these dendritic cells carry this HIV virus to CD4 cells. And once it gets to the CD4 cells, it'll actually reverse transcribe its RNA into DNA and then integrate it into the genomes of these resting T cells. And these resting T cells usually will lay dormant unless they're actually needed. And so this makes it very difficult to treat HIV. And so once now that the HIV is in these T cells, it disseminates to draining lymph nodes. And now we have an established CD4 viral reservoir in lifelong infection with HIV. And so part of what we can do to try to prevent HIV is to break through this transmission cycle. And so the two probably highest risk mechanisms of HIV transmission are through sexual activity and IV drug use. And so the CDC has described a few different mechanisms to try to prevent HIV transmission. Through sexual activity, it's using condoms consistently. It's treating STDs, engaging in lower risk sexual activity. Oral sex actually has a lower risk than anal and vaginal sex as far as transmission of HIV. And then also pre-exposure prophylaxis, or PrEP, which is the medications that we just learned a little bit more about through Dr. Nayer's presentation. And then the other mechanism is through IV drug use. And so how we intervene on this is making sure that our IV drug users have new and clean syringes and needles, and ensuring that they try not to have sex while high on drugs, because being high on drugs usually leads to higher risk behaviors. And for those that can't get access to fresh, clean needles all the time, teaching them, how to clean their syringes appropriately. And the CDC has a step-by-step guide on how to do this with bleach and be safe with it. But then also there's medications such as pre-exposure prophylaxis. And so some of these medications that we have for PrEP, Dr. Nayer talked about these quite a bit. One of them is oral emtricitabine tenofovir disoproxil fumarate. Another is oral emtricitabine tenofovir alafenamide. Another is intramuscular cabotegravir. And so what we know about these medications is these medications are actually HIV treatment medications as well. As many probably know, HIV treatment is usually a 3-drug regimen that usually consists of 2 NRTIs, which is a nucleoside reverse transcriptase inhibitors, which are what emtricitabine and tenofovir are. And then also a third agent that's usually an integrase inhibitor or a protease inhibitor, with most regimens nowadays being an integrase inhibitor, and those integrase inhibitors showing very good efficacy in treating HIV. And so of our PrEP medications, they're regimens that have HIV drugs. The emtricitabine and tenofovir are the backbone of a lot of our HIV treatment regimens. And then this cabotegravir alone, which is an integrase inhibitor, already has a lot of great efficacy on its own, as we've seen with a lot of other integrase inhibitors. And all these medications are very good at preventing HIV without needing more agents like HIV treatment. And it's been shown that these can be as effective as 99% in preventing HIV if adhered to the prescribed regimen. And so we went through this a little bit in the past presentation, but what do you have to do for oral PrEP? As a prescriber, you do need to do a baseline assessment for oral PrEP, which requires HIV screening, because you don't want to give someone pre-exposure prophylaxis when they actually carry the diagnosis of HIV. You want to do STI screening because that's a high risk behavior for HIV. You want to do a baseline kidney function assessment, more so for the emtricitabine and tenofovir disoproxil fumarate. You want to do a hepatitis B screen because, as we learned in the last presentation, emtricitabine and tenofovir actually are treatment for hepatitis B. And the reason why this becomes important for this screening is, people, if they go off of PrEP and they actually have hepatitis B, we can actually see a very aggressive hepatitis flare for intermittently being on these medications and coming off of them. Checking a lipid panel, more associated with emtricitabine and tenofovir alafenamide. And then as far as the dosing goes, it's a once daily oral medication. And you have to take this at least 7 days before you start having sex. That's about the amount of time it takes to build up in rectal tissues. Other areas of the body, it can actually take longer to build up in the system. There is this on-demand or 2-1-1 dosing that was covered in the previous presentation, which is not an FDA-approved means of using oral PrEP, and it's not recommended by the CDC. But the way it works is taking 2 pills of the oral PrEP between 2 and 24 hours before sex, and then taking 1 dose the next day and the next day. And when you're doing oral PrEP, you have to do assessments every 3 months, and that includes HIV screening, STI screening, and then giving them 90-day refills. Every 6 months, you want to do a kidney function assessment, which pertains a lot with the tenofovir disoproxil fumarate. And then every 12 months, checking a lipid panel. And then the injectable PrEP, which we covered in the last presentation, you're going to do a baseline HIV screening, STI screening, and then this oral lead-in to assess tolerance, which has now become optional, which was discussed in the last presentation. You'll do a second dose injection 1 month after that first injection, and then go into the bi-monthly injections. And at these bi-monthly injections, you're going to be doing HIV screening. And so now getting into some of the more important things of, who is actually eligible for PrEP. And so this graphic actually goes into some of the CDC data and who they recommend should be eligible for PrEP. And who is eligible for PrEP for the sexual activity risk factor. It's really anybody that has had anal or vaginal sex in the past 6 months, and then you can kind of go down this flow sheet. If their partner's HIV positive, do you know their viral load, or is their viral load detectable? If their viral load is detectable or they don't know their HIV viral load, you should be prescribing PrEP to these patients. If not, you should still discuss PrEP with them, just because they are in a higher risk category. Then those who are having sex with more than one partner of unknown HIV status, assessing their condom use. If they're not using condoms consistently, they should be on PrEP. If they are using condoms consistently, you should still discuss PrEP. If anybody's had a bacterial STI in the last 6 months, you should consider PrEP. Especially so the men who have sex with men who have had gonorrhea, chlamydia, or syphilis, that warrants PrEP. Men who have sex with women and women who have sex with men, they also would warrant PrEP. But I think the key thing also with this slide is those who don't necessarily automatically qualify for PrEP, it's still recommended to discuss PrEP. And if any of these people request PrEP, it is still recommended to give them PrEP if they request it. And then going into the next high-risk activity of IV drug use. Anybody that's done IV drugs in the past 6 months with shared equipment are at high risk, and they should be on PrEP. I think this is a category of people that we miss all the time as far as who we're prescribing PrEP to. And so looking at all these people that are eligible for PrEP, there's about 1.2 million Americans that have an indication for PrEP. But unfortunately, only about 23% of those with an indication are actually on PrEP. And I think if you look at this graph, it kind of shows the disparity of who has an indication and who's actually being covered. And so about 63% of white Americans are being prescribed PrEP that have an indication. Compared to African Americans and Hispanics, it's 8.2 and 14%, which is very low for the amount of people that actually have that indication for PrEP. I think it's interesting then, you compare this uptake of PrEP and who's on it compared to the prevalence. And it just kind of highlights the disparity of HIV in general in the US. African Americans and Hispanics make up about 70% of the HIV diagnoses, but yet are less likely to be on PrEP compared to white Americans. I think this is a very key thing to highlight, and I think it's something that we need to work on. And so, why aren't people on PrEP? Well, some of the barriers to the PrEP uptake is, awareness of PrEP. We as providers, we don't always assess people's sexual history. We do a great job of assessing for alcohol use and tobacco use and drug use, but we don't probe into people's sexual lives. And if we did, we'd probably identify a lot more people that would actually be eligible for PrEP, and at least to have that discussion and discuss the risks of their sexual activity. Another barrier is the HIV risk perception. So HIV is not in the news as much as it once was, and so people's perception of risk of acquiring HIV is a lot lower. Then the stigma related to PrEP. Yeah, the HIV still carries a heavy stigma despite us having very good treatments for it. I know personally some of my patients, they've lost partners because they've had antiretrovirals at home, and their partner thinking that, oh, my partner has HIV, I don't want to be with them anymore. And it's always heartbreaking to hear about this, that having a patient that's being responsible, being on PrEP, and they get dumped because they're being responsible and they're on appropriate medications. I've had other patients that are afraid to have the medications at home because they're afraid their family will judge them. So there is still a lot of stigma related to HIV that we need to do a better job of addressing. And other barriers to PrEP uptake are distrust in the healthcare system, access to medical care, lack of access to financial assistance. And when we look at some of the gap in PrEP coverage, this article in JAMA mentions that there's more likely to be gaps in PrEP coverage in African Americans, the Latinx community, young adults aged 18 to 25, substance use disorder, women, and then people of low socioeconomic status. And this population of people are also less likely to both receive a PrEP prescription and to initiate PrEP, and more likely when they are on PrEP to discontinue PrEP. And so it's both trying to get people on PrEP, but also trying to retain people to stay on PrEP. And this table from JAMA also kind of shows that there's a higher incidence of HIV for that population of people that aren't on PrEP. And so the adherence issues with daily oral PrEP, because it is something that's difficult to stay on, the medication regimen itself, it's a daily oral medication that you have to be on. And if you're engaging in, for the men who have sex with men population, it takes about 7 days for it to build up in rectal tissue. And it takes about 21 days to build up in other areas of the body for it to be an effective regimen. And so for a lot of people, it's kind of hard to plan in advance their sexual activity looking a week, 3 weeks out. And for some people, it's very challenging. And so that becomes a barrier to people continuing to take PrEP. So some of the socioeconomic factors, people don't get a lot of social support from their family and friends for PrEP. The stigma of HIV, which I already kind of talked about, is also an issue for people not being on PrEP because they don't want to have antiretrovirals at home because people will think that they actually have HIV. And then looking at factors of just daily living, people have busy schedules, and sometimes it's hard to take a daily medication. And if you look at the population that are at higher risk, it's this younger population that aren't actually on any medications to begin with. And so suddenly trying to get them to take a medication daily as a preventative measure is a hard thing to ask sometimes. And then, people just simply forgetting to take meds, or, people are away from home and they forget to bring medications with them, or, people are traveling. It's hard to remember to bring the meds with them. And again, a lot of this kind of pertains to some of the younger population that are at higher risk. And then also perceived kind of side effects from medications. And then there's just a lack of awareness about HIV PrEP. And so then going into a little bit about how to address this PrEP access and adherence. So we know that the oral medications, they're very effective if they're taken correctly. They're taken daily. They're taken well ahead of having sex. And so looking into this, longer acting options that don't require a daily medication. And so how can we help these patients? As is kind of touched on in the last presentation, There's a lot of research going into this. That NIAID is funding research into these 4 different long-acting types, one being an intravaginal ring, one being an implant, injectables, and then also antibodies. And this injectable is more talking about cabotegravir currently, which is something that we're still kind of actively trying to get out and trying to use and trying to work into our clinics. And so looking at, what populations, would be good to have a long-acting option for, like something like cabotegravir. So I think looking at populations like the homeless, people with substance abuse, people or sex workers, where, these populations, it's very hard to keep oral medications on them at all times. A lot of people don't have stable housing. They don't know where they're going to be living next to the next. And so it's hard to keep a stash of medications with them and take them every single day. And so these people that don't have stable social lives, giving them a one-time injection and having them come back every couple months for this injection could actually be very beneficial. People with mental health disorders, it's also hard to take a daily medication. People with busy schedules, people who are going to be traveling frequently, these are also great populations that this medication could be useful for, doing an IM cabotegravir. I think, some of the key takeaways from this presentation, about 80% of new HIV transmissions are from persons who do not know they have HIV infection or are not receiving regular care. HIV disproportionately affects Black, African American, and Hispanic Latino populations. Transmission primarily occurs through sexual activity and IV drug use. PrEP is underutilized by Black, African American, and Hispanic populations. Oral PrEP is efficacious, however, it can be difficult to maintain adherence. And then injectable long-acting PrEP may be a tool to improve PrEP utilization and decrease HIV transmission in underserved populations. And then just going through, I guess, the last questions. I don't know, should I go through these right now?
Yes, please.
Okay. And so the first question at the beginning of the talk, which of the following medications are approved for HIV pre-exposure prophylaxis? Option A being bictegravir, tenofovir, alafenamide, and emtricitabine. And then the next 3 being PO, tenofovir, alafenamide, emtricitabine, tenofovir, emtricitabine, IM cabotegravir. It's going to be B, C, and D, which is answer F. Answer A is actually one of the most commonly prescribed HIV treatment medications, but not used for pre-exposure prophylaxis. And then our second question, which persons would be eligible for PrEP? So as you saw on a lot of those flow sheets, there's a lot of people that would be eligible for PrEP. And so, A man who has sex with men with 2 partners in the last 2 months without consistent condom use would be one. Women who have sex with men with 1 partner in the last month and 1 episode of rectal gonorrhea, that bacterial STI would definitely qualify them. Men who engages in IV drug use 1 to 2 times per month with shared needles, all these would be eligible for pre-exposure prophylaxis. And with that, that's the end of my presentation. Thank you so much for having me here and to be able to talk about HIV PrEP and some of the epidemiology related to it.
So thank you, Dr. Davis. You really highlighted about who could be eligible for these important oral medication regimens, and then who's most likely to have improved adherence with the long-acting injectables. And I think you've made a great case for our providers to really look at how do we decide what regimen from a precision medicine standpoint is the most appropriate for their patient based on the social determinants and other issues according to their lifestyle. So thank you so much for that presentation. We appreciate it. And we will now move on to our last speaker, Dr. Virginia Banks, who is a MD, MBA who graduated from Case Western Reserve School of Medicine in Cleveland, Ohio. She completed her internship in internal medicine at the Cleveland Clinic Foundation and 2 years of residency and in her infectious disease fellowship at the University Hospitals of Cleveland. And Dr. Banks is a fellow in the Infectious Disease Society of America and was the first Black or African American to receive the prestigious Wantana Kunakon Clinician Award. And so she's currently with Northeast Ohio Infectious Disease Associates in Youngstown, Ohio. She is a prior head of infectious diseases at University of Pittsburgh at the Horizon campus. But without further ado, she's going to come and talk to us about how PrEP can be utilized in our adolescents and pregnant women. Thank you.
Thank you. Thank you for having me. Thank you, Dr. Kane. Thank you, the Internal Medicine section of the National Medical Association. Thank you, BlackDoctor.org, Mr. Dean. I'm very happy to be here today to talk about this topic of PrEP in adolescence and pregnancy. So I wondered, I'm not sure, can my slides come up larger on the screen, or is this it? We're unable to do that. Okay, thank you. Next slide, please. Or can I control them? Next slide, thank you. I have no disclosures. We're going to do the pre-test first. All drugs are indicated for PrEP except FTDF, FTAC, FTAF, and ritonavir. Next slide. Providers should offer PrEP with M-tricytidine and tenofovir diproxyl fumarate to women seeking to conceive and pregnant or breastfeeding women whose sexual partner has HIV, especially when their current partner's viral load is unknown. True or false? Third, which drug used for PrEP is indicated in men and transgender women only? M-tricytidine and tenofovir alafenamide, or M-tricytidine and tenofovir diproxyl fumarate. Okay. The years-long surge in sexually transmitted diseases in the United States has continued in 2020 during the first year of COVID-19 pandemic, and there are indications that cases are still increasing, the CDC has warned. This affirms once again that America really is not taking the STD crisis seriously, said David C. Harvey, Executive Director of the National Coalition of STD Directors. And I'm going to be using STDs and STIs interchangeably in this presentation. Because I'm quoting some people, and that's why I'm doing that. We can only fight this out-of-control epidemic with new funding and the kind of urgency that reflects the enormity of the crisis. According to surveillance data, 32% of all STD cases in 2020 occurred among non-Hispanic Black people, who make up only 12% of the United States population. In the United States, 21% of new HIV diagnoses in 2019 were among young people aged 13 to 24. 88% of youth who received a new HIV diagnosis were young men, and 12% were young women. From 2009 to 2019, the CDC data showed declines in sexual risk behaviors among high school students. And the percentage of high school students who ever had sex decreased from 42% in 2009 to 38% in 2019. I think my head is in the way of this last comment. And condom use also decreased, thank you, from 61% in 2009 to 54% in 2019. So it's estimated that young people aged 15 to 24 years of age acquire half of all new sexually transmitted infections annually. I found this very surprising, this next statement. 1 in 4 sexually active female adolescents in the United States has an STI. Lower use of health care because of concerns regarding confidentiality. These are things that are quite bothersome. Limited awareness of the need for screening and logistical barriers that could include just things like transportation and cost, which we saw not necessarily with cost, but transportation is a problem that we saw in terms of disparities with the COVID-19 crisis. The authors sampled from the 2019 Youth Risk Behavioral Surveillance, YRBS, was limited to students who reported having had intercourse within 1 or more people in the last 3 months before the survey. Next slide. Of that group, 1/5 reported testing for an STI in the previous year, with a higher proportion of female than male students reporting testing, about 26.1%. Among eligible responders, 4.1% reported they were not sure if they had an STI test in the last 12 months. There is need to both increase adolescent access to preventive health services as well as to ensure youth receive quality health care when at the clinic so as to reduce missed opportunities. And this is from a group out of the Nationwide Children's Hospital in Columbus, Ohio, Doctors Holland Hall and Dr. Andrea Barney. Next slide. Dr. Leandro Mina, who is the director of the CDC's Division of the STD Prevention, said the COVID-19 pandemic increased awareness of something we've long known about STDs, social and economic factors such as poverty and health insurance status create barriers, increase experiences with health risks, and often result in worse health outcomes for some people. It seems to me that we heard a similar quotation by Dr. Fauci when it became apparent that healthcare disparities were a big problem with the COVID-19 pandemic. Next slide. So before the COVID-19 pandemic, gonorrhea, chlamydia, and syphilis were all reported at record high rates in the United States, with about 1/2 of all new infections occurring in adolescents and young adults. The youth survey that I mentioned previously, data showed that 20% of high school freshmen and more than 50% of high school seniors have had sex, whereas less than 1/2 reported having used a condom with their most recent sexual encounter. So there's a recommendation for opt-out. What is opt-out? Patient is notified that STI testing will be performed, and they may decline this testing if desired. There is some data to suggest that opt-out testing may improve, could you move that up a little bit? May improve detection rates and be cost effective. Next slide. So what about substance use and high-risk behaviors in PrEP? Nationwide, 27% of all students are currently sexually active. That means they've had sexual intercourse during the previous 3 months, and 21% of those students drank alcohol or used drugs before their most recent sexual intercourse. Some youth are at higher risk. Some youth, including lesbian, gay, and bisexual youth, are at greater risk for negative health outcomes. For example, 11% of LGB students have had sex with 4 or more partners during their life, compared to 8% of heterosexual students. LGB students, 4%, were also more likely to have ever used injected illegal drugs than heterosexual students, 1%. Next slide, please. So only 1/5 of sexually active high school students reported receiving STI testing within the previous year. Suboptimal adherence, which is a problem which has been talked about by both of our previous speakers, to national guidelines from the AAP and others, the American Association of Pediatrics, which advises testing for all sexually active women and certainly young men aged younger than 25. Data from 2019 National Youth Risk Behavior Survey included for the first time a question about the annual STI testing. Next slide. So schools can help prevent HIV, but as we know today, May the 21st, 2022, when we talk about schools and testing, and I know I went to a junior high school this past year to talk about the COVID pandemic and my career as an infectious disease specialist. I was asked not to talk about COVID vaccines. How can you talk about the COVID pandemic without talking about the vaccine? So schools can be helpful, but in this era, we must be careful about information that we're allowed to give. So we need to, of course, teach students the basics about HIV and other STDs, promote communication between youth and their parents and families, support student access to confidential HIV counseling and testing services, and connect students to health services that include HIV testing and counseling. I take PrEP because I'm in control. Next slide. Evidence supporting PrEP for adolescents. The expanded indication for PrEP was based on 2 adolescent-focused safety studies. The Adolescent Medicine Trials Network for HIV/AIDS Intervention, ATM-113, and Plus Pills. So ATM-113 was found to be safe and well tolerated among a cohort of racially diverse young men who have had sex with men ages 15 to 17. The Plus Pills study was conducted in South Africa among adolescent boys and girls aged 15 to 19. In this study, PrEP use was also found to be safe, acceptable, and tolerable for the Plus Pills participants. But adherence dropped in the second half of the study in a pattern that was similar to what was seen in the ATM-113 study. Next slide. So PrEP is recommended for adolescents weighing at least 35 kilograms or 77 pounds who report sexual or injection behaviors that indicate a risk for HIV acquisition. For both men and women, PrEP daily with emtricitabine and tenofovir disoproxil fumarate is indicated. For men only, daily oral PrEP with emtricitabine and the newer formulation of tenofovir alafenamide, is a recommended option for HIV prevention for adults and adolescents. PrEP with emtricitabine and tenofovir alafenamide has not yet been studied in women, persons assigned female sex at birth whose gender identity is female. Renal function should be assessed. And then we've heard a lot today about the newer injectables. Cabotegravir is approved by the U.S. Federal Drug Administration for use as HIV exposure, for use as HIV exposure. And we've heard our 2 previous speakers talk about this. Next slide. So I have a couple of clinical care models, and these are all on the CDC website for your perusal. This first slide is this first graphic shows the essential elements and the basic flow of PrEP care in a clinic. PrEP clinical care includes identifying and engaging patients in the need of PrEP, conducting necessary exams and lab tests, and prescribing PrEP for the patients, as well as ongoing patient monitoring with follow-up visits and prescriptions for as long as the patient needs PrEP. Next slide. This next slide is a collaborative model. And again, you can find all of these on the CDC website. And this is looking at, and Dr. Kane might want to comment on this in the question and answer period. Health departments fund, guide, and lead collaborative planning and delivery of health protective measures like PrEP. A public health model for prevention with PrEP includes national, state, and local levels of public health collaborating with and supporting clinics and non-clinical community-based organizations to ensure that PrEP is available, accessible, and accessible. So you sort of see this, which could really be a Venn diagram as I think about it also, but it's a collaboration of community-based organizations and their modes of delivering information about PrEP. You have mobile units, you have the primary care delivery system, you have other types of clinics, which include other types of clinics in your community, and of course the health department as well. Next slide. You know, I like infographics because I think a picture is really good. And I try to, when I'm giving other talks to young adults, use infographics to explain and talk about just issues like PrEP. Here is one from CDC. Next slide. So the United States Preventive Services Task Force released a rating for PrEP for adolescents and adults who are at high risk for HIV acquisition. The Society for Adolescent Health and Medicine position states that adolescent and young adult health professionals should develop evidence-based, developmentally appropriate, culturally sensitive, this is extremely important, and accessible PrEP service delivery models, like I showed you before, as part of routine care offered to adolescents and young adults. Providers are encouraged to counsel patients about PrEP, describe it as a safe and effective HIV prevention strategy in combination with condoms, and refer patients to available providers for initiation and monitoring of PrEP. Next slide. Disparities. We've heard this word so much in the last couple of years with the advent of the COVID-19 pandemic, like it wasn't there before, but a new light has been shined on it, and no less with sexually transmitted diseases and PrEP. The limited number of prescriptions overall that are provided to youth may be directly related to a lack of provider knowledge about PrEP and discomfort with providing PrEP. I can tell you from personal experience that when I was getting ready to give this talk, I walked into the doctor's lounge. Several of my colleagues were in there, and I just kind of queried. They were from all different subspecialties. And I just sort of asked them, how many of you all have ever heard of PrEP? And I just said PrEP. And I think maybe of about 10 of them in the room, 2 of them raised their hands. So, I mean, this is a problem, you know, and I just think I don't think it should just be limited to primary care physicians. I mean, I think that really any opportunity that a physician gets for somebody coming into their office might be an opportunity to discuss this. And knowing that these drugs have revolutionized the acquisition of HIV, is a missed opportunity. One study of primary care physicians' attitude regarding PrEP use for adolescents found that just 37% of clinicians were somewhat or very familiar with PrEP. So what are the barriers? Adherence, safety and side effects, concerns about parents as a barrier, and a lack of physician knowledge again. One study found that clinicians reported greater intention to prescribe PrEP to adult versus adolescent men who have sex with men and transgender women. Next slide. So what are the new pre-exposure prophylaxis for prevention of HIV infection? These are the updates from 2021. Number 1, inform all sexually active adults and adolescents that PrEP can protect them from getting HIV. Providers should offer PrEP to anyone who asks for it, including sexually active adults who do not report behaviors that can put them at risk for getting HIV. Next slide. Again, prescribe. We talked about this today. I won't go over it again. And again, prescribe the newer kid on the block, cabotegravir injection for PrEP for sexually active adults and adolescents. Next slide. This slide, again, is an algorithm which we've talked about today with our previous speakers. I believe Dr. Davis showed that. And it's just another algorithm talking about prescribing PrEP. Next slide. Another algorithm, again, for assessing sexual risk for all people who inject drugs, starting out with if you've ever injected drugs, then yes or no, and getting down to whether they should be prescribed PrEP or prescribed if required. Next slide. Confidentiality is critical to building an effective patient-provider alliance. The assurance in the presence of the parents and or legal guardian that discussions between the adolescent and provider will not be breached unless reportable events such as abuse or suicidal or homicidal thoughts are disclosed encourages adolescents over time to seek health care and respond candidly to potentially sensitive topics. Such topics include sexual activity, sexuality, and or gender identity concerns, substance abuse, pregnancy concerns, dating violence, and contraception. Providers should also be familiar with their state's minor consent laws and share this information with office and or practice staff, patients, parents, and or legal guardians. Currently, all 50 states and the District of Columbia allow minors, age varies from 12 to 14 years, to consent to testing and treatment of STIs without requiring parental notification by providers. And consent for HIV testing and or treatment is currently allowed by 32 states, including the District of Columbia. However, if you're like me, I continue to trust but verify. I continue to look to see what the laws are to see if they're changing, to see if I'm in compliance and so forth. Next slide. Oh, I'm sorry, this slide, thank you. All research on PrEP cited in the guidelines 2021 was conducted in cisgender women, defined as denoting or relating to a person whose sense of personal identity and gender corresponds with their birth sex. So there are no data yet about transgender men, genderqueer, or non-binary individuals who have become pregnant and given birth while taking PrEP medication. An increased risk of HIV acquisition has been documented for women during periods of contraception, pregnancy, and breastfeeding. Providers should offer PrEP with emtricitabine and tenofovir desoproxil fumarate to women seeking to conceive, that is, sex without a condom, and pregnant or breastfeeding women whose sexual partner has HIV, especially when their current partner's viral load is unknown, is detectable, or cannot be documented as undetectable. Women whose sexual partner with HIV achieves and maintains an HIV viral load less than 200 copies per milliliter are at effectively no risk of sexual acquisition of HIV. Next slide. The FDA labeling information is, thank you, permissive of use of emtricitabine, tenofovir desoproxil fumarate for PrEP in pregnant and breastfeeding women. The perinatal antiretroviral treatment guidelines recommends PrEP with emtricitabine and tenofovir desoproxil fumarate. Data directly related to the safety of PrEP of a developing fetus were initially limited. So the emtricitabine, tenofovir desoproxil fumarate PrEP trials were heterosexual women. Medication was promptly discontinued for women who became pregnant, so the safety for exposed fetuses could not be adequately assessed. A recent analysis of 206 Kenyan women with prenatal PrEP use and 1,324 without found no difference in pregnancy outcomes, preterm birth of low birth weight, and similar infant growth at 6 weeks postpartum. One more statement. Can we go back? In the parent Kenyan study of 193 pregnant or postpartum women with partners living with HIV, 153 initiated PrEP and none acquired HIV. Next slide. So, tenofovir desoproxil fumarate and emtricitabine, also again tenofovir alafenamide, are widely used for the treatment of HIV infection and are continued during pregnancies that occur. Providers should discuss the potential risks and benefits of available alternatives for safer conception, rather. Providers should include discussion of the potential risks and benefits of beginning or continuing PrEP during pregnancy and breastfeeding so that an informed decision can be made. It's really important to send these patients to the experts so that they can discuss the necessary possibilities, what is safe, what has been found to be safe or not. The safety of PrEP, I'm sorry, the safety of PrEP with emtricitabine and tenofovir desoproxil fumarate, or emtricitabine and tenofovir alafenamide for infants exposed during lactation has not been adequately studied. Data from studies of infants born to HIV-infected mothers and exposed to both these drugs, or tenofovir desoproxil fumarate, or tricitabine through breast milk, suggest limited drug exposure. I think my last two slides. So the overall goal, again, aiming towards ending the HIV epidemic, increase the estimated percentage of people with indications for PrEP classified as having been prescribed PrEP to at least 50% by 2012 and remain at 50% by 2030. As an infectious disease specialist who was involved in the trenches this past year in COVID-19, I know a lot of things kind of got pushed by the wayside. But again, I am encouraging all healthcare providers to get back in there and continue to prescribe PrEP, because I've been around since the 1981 when HIV was first talked about, and I believe that these drugs, in my opinion, during my lifetime, during my career, have and will revolutionize this disease. Thank you very much. This is the end of my presentation. Again, National Youth HIV/AIDS Awareness Day is April the 10th. Thank you very much for inviting me. I think you're muted. Dr. Kane, are you muted? I can't hear you.
Sorry, I was muted. Apologize about that. Okay.
I was going to say I couldn't hear you.
Thank you, Dr. Banks, for that presentation related to adolescents and pregnant women and the new recommendations that have come out with the guidelines most recently. So really appreciate the information that you have provided. I would now like to introduce you to Dr. Wilbur Jordan, who is an associate professor of medicine in the Division of Infectious Diseases at Charles Drew Medical School. Dr. Jordan is a legend and is the founder of the Oasis Clinic out of the Charles Drew Medical School, which may still be, but definitely at one time had the largest number of HIV African-American patients in the country. But his claim to fame is that he was one of the first providers to identify the first HIV patient in Los Angeles, California, when we were first identifying our first patient in New York City, and well known for his advocacy for HIV rights, has been on the faculty for the HRSA HIV guidelines. I would like to have Dr. Jordan come on to give a wrap up and maybe also go over and have individuals give our post-test questions if possible, and to invite him to give us insight about where we are with this epidemic.
Well, thank you. And hello to Dee, if she's still on. She was a former classmate.
Oh, wow.
Or schoolmate, rather. I was a senior and she was a freshman. Brings back a lot of old memories. There are 2 points I really want to discuss about this so we can look at how we can get a good handle on this. One, looking at the data from our patients at OASIS, we found that 64% of the men gave a history of being molested, 88% of their sisters, and of the women patients we only have 2 out of a 40-year history who did not have a history of being raped or molested. So I think when we look at getting a hold on HIV in our community, mental illness is another issue we have to deal with. Now, I'm working with the Student National Medical Association, and I hope that most of the people on this were one-time SNMA members. SNMA is the student organization. It has chapters in every city. And one of the things we're doing now is getting SNMA over the next 3 years to take on as a project to get people in the community to enroll in PrEP. So let me give you the stages that we're going to do, and hopefully you all may want to interact. So the first thing, we want to get each chapter, and let's just use Philadelphia as an example. There are several schools in Philadelphia. We're at each school to have each chapter first identify 2 to 4 primary care physicians so that when they do start doing outreach, they will have names of primary care physicians to refer patients to. Those physicians named, we will do something like this, a Zoom, to deal with how to prescribe the medicine, as well as what the medicines are. And so they will know that information. And we will also deal with the issues of comfort. So the whole point of having the student chapters approach physicians in their community is to ask, are you comfortable prescribing meds? Because unfortunately, a lot of physicians are not comfortable in terms of their approach. I don't need you saying something like, I didn't know you were like that. I didn't know you were one of those. Those
So
are not
Dr. Jordan, I'm going to interrupt you. And I'm going to say that when we look at our physicians, especially in the Black community, we know that about 80% of our primary care providers, if you had a heart disease or you had hyperlipidemia, they don't have a problem treating that, hypertension, high cholesterol, even diabetes. But when you look at this is one of the best prevention tools in the country. We could really eliminate HIV with this. The overall uptake of our providers, even offering it to our patients, is 25%, and that's for all races. But we see like that 65% uptake by white patients, and then we're less than 10% for Black patients. Where is this disconnect with our providers?
That's what we have to deal with. And we can't sit by and talk about somebody else. That is something we have to do. And so I'm happy that SNMA is helping us do that, because that's one of the big problems. We're not. And a lot of our physicians are uncomfortable. There are some cities in this country where Black patients with HIV cannot go see a Black provider. We have to change that. And so that's one of the things we're doing.
So would you suggest that we may need to get some type of repository list of providers in the different states where
that's what we're going to do.
Can access
what we're doing through
these
SNMA.
providers?
We will identify physicians in each of the major cities, so that when we then do the outreach to get people to go see a doctor, we will have the name. We would have trained them, and we will have names of physicians for them to go to, so they're not worried about having people turn them away, not do things, but get them on treatment. You know, it's been said by all the speakers, we have now the capability of dropping the rate of HIV down to 0. There are good medicines that if you're HIV positive, if you take them, basically you won't be able to infect anyone. And if you're HIV negative, there are drugs out and there are drugs coming out that if you take them, you can't get infected. So we should not still have a high number of people getting infected. And we still have a high number of people getting infected. And that, I argue, we have to be the one to control. We can't look at CDC or state health departments or the state of Texas to do that. We have to be the ones doing that. But those are the things that we want to do. We're doing with SNMA. So first thing is identifying physicians. Second thing is teaching them through Zoom, just like this, how to treat the patients. And then the third would be having the chapters go out and by city, encourage people to get tested and do things. And I'm hoping this will be a way that we can really get that large number of young Blacks who are at risk to get them on PrEP, get them in treated, and we can really cut the rate down. There's no reason for people, we still have patients coming in, they've been infected for 11 years, and you've lived in Los Angeles. Why have you not come in before? I mean, what was going on? You can't get it healed. Excuse me. So you can go to every church in the city, and everybody put their hands on your head, your knee, your behind. I don't care. You're not going to be cured. We still have people who believe that, and it's really frustrating when you have someone come in and their immune system is 80% destroyed because they have not sought the care when we have it. But stigma is still very important. And we have a night clinic because a lot of patients don't want to be seen. They're afraid if someone sees them. And in 2022, that is still a major concern.
Well, let me just say this. I think with some of the newer drugs that are coming out, the possibility that we could have a drug where you might only have to have 2 injections in 1 year.
Right.
Or you might have a vaginal ring that's just sort of like an oral contraceptive ring that can provide protection for 1 year. I think we're really near cutting edge technology that's going to be huge. But let's first bring up our post-test questions, if we can, to go through the post-test questions. We're going to ask everyone, if you can, bring up those questions. And if you could answer those questions, we would appreciate it. And as you can see,
I can't see them.
Can you see the first question? So if the first question is, what is the frequency of getting the injectable cabotegravir PrEP? So is it, do you get that injection every 2 weeks after you've, of course, did your loading of the oral PrEP prior to that? Or do you get cabotegravir every 6 months for PrEP?
Every 2 months.
Every 2 months is the answer. Thank you. And then the second question is how to screen for HIV while on PrEP. If you're going to start someone on PrEP, in that initiation, especially in that first week before starting them on PrEP, is a HIV antibody test sufficient, or should we be using a HIV viral load?
You can do a viral load.
Yes, because a lot of times people don't realize that even after someone becomes infected, it may take 2 to 3 weeks for them to develop an antibody, and they may very well be positive. But the viral load actually identifies actual quantity of the virus particles in a person's body. And so then the third question is, which of the following medications are approved for HIV exposure prophylaxis? Is it oral Pidagravir, tenofovir, or is it tenofovir alafenamide with itracytopine? Or number C, is it tenofovir disoproxil fumarate itracytopine? Or is it D, the intramuscular injection cabotegravir? Or E, was it all of those above medications?
It's B, C, and D.
So it is B, C, and D, because we know number A is one of our most common drugs we use for actual HIV treatment, but not for prevention. And so
and anyone here listening now should contact their pharmacy, because if you're not regularly treating patients with PrEP, they may not have any of these three, and you should decide. Now, if you're treating women, then the alafenamide, tenofovir is not approved. So it depends on what kind of client you have as well. But I think for those listening, please know that all three of the drugs work very well. I have never had a patient have to stop because of any kind of side effects. The biggest problem I have had is the issues of stigma. And stigma is both, for male, it's both the stigma of my sexuality as well as being HIV, and for women, it's the stigma of having HIV and the consequences. And I think those are important issues that we have to deal with. And if you want people to take the medicines regularly and effectively, we have to deal with those two things as well.
So thank you very much. I don't know if we have any more questions in the chat at all for us. And we could bring Dr. Banks back on the screen.
Hi, Wilbur.
So let me just say, I don't see any more.
Dr. Kane, there's a question. The recommendations are not blanket recommendations for cisgender men/women, transgender men, women, and non-binary people. Dr. Jordan, help me out with this. I believe when I reviewed the 100+ pages of the updated guidelines, I don't believe all of these individuals were studied.
Correct. Most of the men studied for MSMs, transgender men.
That's what I thought. So I just wanted to answer that question from Mr. Ace Robinson or Dr. Ace Robinson.
So I think that the new TAF drug that was used, that was for sexually active men and transgender women for HIV acquisition, excluded the persons at risk who were through receptive vaginal sex, including cisgender women. Remember, these are persons assigned female sex at birth whose gender identity is female. So not enough studies have been done on all of these high-risk populations, but we hope to hear more details and more findings later. Thank you. So this ends our program. We appreciate you attending this particular webinar session. We hope to continue to have future webinar seminars. And we'd like to invite anyone who would like to work with the National Medical Association on ending this HIV epidemic. I think that we could be wonderful resources across the country. We know that over 50% of the cases are heavily hit in the southern states of the United States. We also know that 42% of all the new cases for HIV are in African American patients, with about 29% in Latino patients. But if you like this broadcast, let us know, and please share this broadcast with all of your friends and partners. We really need other Black providers to help push the FDA on access to the vaginal ring. And so that is something that we are very concerned about, because we believe that Black females can be the ones most impacted by this decision. So it's important that we look at all different screens of innovative alternative interventions. And so just invite any comments or opinions to us, to the National Medical Association, in regard to this effort. So again, I want to thank our sponsors. I want to thank our dynamic faculty, Dr. Nair, Dr. Davis, Dr. Banks, and Dr. Jordan, who is our co-chair for this program activity, along with myself. And so have a good day, and let's make a difference in the lives of our Black patients in the United States. Thank you very much.
Thank you.